Now I'm going to go back to this slide right here. Now y'all listen to this. This is important.
Make it big.
Do y'all remember we talked about, somebody mentioned sludge patient? A patient that's been exposed to what?
Organophosphate.
Organophosphate poisonings. Now, if this were the heart, SA no to the heart, and this is a parasympathetic nerve fiber here. This will be the vagus nerve coming into the heart. Then we have what chemical here? Acetylcholine is being released. All right. And then I mentioned the enzyme that gets rid of the catecholamines earlier, dopamine, epinephrine, norepinephrine. The enzyme that gets rid of the acetylcholine after it's out there and degrades it and breaks it down so it can be reproduced back in this presynaptic neuron here. The enzyme that does that for the parasympathetic nervous system, do y'all remember what it is? Acetylcholinesterase. And the way that an organophosphate poisoning works is it ties up that enzyme so that the acetylcholine that's been released out here cannot be degraded by acetylcholinesterase and sent back into the presynaptic neuron. So it causes a buildup of acetylcholine in that area. If you tie that enzyme up, which is exactly what organophosphates do, they tie up acetylcholinesterase. What happens in that synapses? There's a buildup of what? Acetylcholine. Acetylcholine gets built up there, and that's what gives you the parasympathetic overdrive that organophosphates cause. Now, the first treatment for that would be to what? We have a whole bunch of acetylcholine out here that's attaching to these receptors and causing the bradycardia in the sludge patient. So we need to give atropine to block those receptors. Okay? Atropine would immediately stop that parasympathetic overdrive because it would simply block these receptors where the acetylcholine that's built up here can't get to those receptors. Okay? Then, and usually it's given in higher doses. You know, we give atropine 0.5 milligrams. You know, for somebody it's bradycardic from a cardiac condition. We will give organophosphate poisoning patients higher doses. I believe if you look in the back of your book, I've seen 2 to 5 milligrams at a time. We're trying to dry the patient's secretions up, dry their wet lung sounds up, speed their heart rate up. The second step in that will be to do what? After you've blocked the muscarinic receptors from the excess acetylcholine, then the next step will be to give a second drug called pralidoxime or 2-PAM chloride, and that actually frees up the enzyme acetylcholinesterase from the organophosphate poisoning, and that then allows the enzyme to do what? Begin to break down the excess acetylcholine. Okay. Now, you probably won't be giving the 2-PAM chloride in the field. Not carried by many ambulance services, especially in our area. But if you can run across these type calls where the farmer's been spraying insecticide all day. You get there and you find that the typical sludge patient. You figure it out in your history and your physical, and without contaminating yourself, you get to where you can treat your patient. Atropine is really what you'll give the patient on the way to the hospital. It's not likely that you'll be carrying 2-PAM chloride with you, or pralidoxime. All right. But atropine simply blocks those muscarinic receptors to prevent the excess acetylcholine from continuing to cause parasympathetic overdrive. And then at some point the patient will need to receive 2-PAM chloride to free up the enzyme acetylcholinesterase so that it can then get rid of the excess acetylcholine. Any questions? All right. Yes, sir.
So what if the patient's on an ACE inhibitor?
An ACE inhibitor.